Hello, I'm Marina Hughes, and I'm really grateful and honoured to be invited to share this talk with you at the PCSI meeting this year. I'm hoping to convince you that cardiac MRI really does have a very important role, complementary to echocardiography, in examining and looking after our patients with Ebstein malformation. I have a long history in non-invasive imaging and started my career with echocardiography, but for the last 20 years or so have been involved with cardiac MRI for patients, both pediatric and adult, with congenital heart disease. And I don't need to tell this audience about Ebstein malformation, but I just want to reiterate that this is a disorder of the myocardium and the valve, and that there's a huge variety of morphology and physiology, ranging from the patient in the inferior panel with almost no functional right ventricle and only surviving because of an atrial communication and a cavopulmonary shunt to supplement the left ventricular filling, to the patients in the middle two panels, much more typical of our common view of Ebstein malformation, with severe regurgitation of the tricuspid valve and with severe dilatation of both the right atrial and right ventricular chambers. But the patient in the top panel also has Ebstein malformation, but has restrictive physiology without severe regurgitation of the tricuspid valve, but with prognostic features for their conduction and for their outcome specific for a Ebstein malformation of the valve and the ventricle. So with this large range of right ventricular and valve right heart abnormalities, there are also commonly associated left ventricular myocardial abnormalities, particularly non-compaction, and obviously conduction abnormalities as well. And so with that, there is a huge range of symptoms and problems related to Ebstein malformation, with no single measure of severity because of the wide spectrum of disease. And with all of this variability, there's a multitude of different interventions that we offer at varying stages in the life of a patient with Ebstein malformation. But all of these interventions only give palliation of the hemodynamics. There's no cure for this disease. And so we use a whole repertoire of imaging and other diagnostic tools to help us make decisions along the way. But fundamentally, echocardiography is the first line decision tool and imaging tool for this malformation. Echocardiography is crucial at every stage, from antenatal to immediate postnatal and prior to and after all the interventions. And it's in fact echo that provided our first main outcome measure, with this study from Great Ormond Street now 30 years ago, showing us that it was the relative size of the right heart compared to the left heart that gave a very strong predictive capability for outcome and survival of the neonate. But we've moved beyond just survival as an outcome measure to more granular measures of hemodynamic efficiency and quality of life. And echocardiography in all of those stages helps that very difficult balance of intervention and likelihood of success of intervention with the risk of clinical medical management and watchful waiting. And the question is whether MRI can help to poise that balance for all patients repeatedly at every stage for life. And I put it to you that MRI does help that balance, and the parameters from cardiac MRI can be outcome measures themselves or can be used to predict other outcome measures. And so now there's quite a large repertoire of studies, admittedly cross-sectional, mostly short-term, almost all single center and relatively small numbers. But these do show that MRI parameters can predict exercise capacity, adverse events, arrhythmia, and heart failure. And with these MRI parameters, we can incorporate other measures of function and risk, but mostly have to include anecdotal and very piecemeal data to help make decisions with very poor prediction in truth as compared to some other congenital lesions. And fundamentally, the diagnosis is even difficult for this disease. And I think MRI can help to give a broader view and a larger vision of the nature of the valve and the ventricle to help specify the diagnosis. The patients in the left-hand panels were diagnosed as having Ebstein malformation, but the superior patient had a dysplastic valve without lamination that required a very different surgical intervention. And the patient in the lower panel, in fact, even with severe right atrial dilatation and severe tricuspid valve regurgitation, does not have any lamination of the leaflets, but in fact has an atrial appendage aneurysm. The patients in the right-hand panels were thought not to have Ebstein anomaly, but in fact do, with a rare kind of anterior leaflet lamination in the top patient, and with very little valve regurgitation, but definite lamination, but with restrictive physiology for this adult patient in the bottom panel. So if a patient is safe to go in an MRI scanner, can tolerate the MRI environment, then MRI offers a 360-degree characterization of the valve. And this is crucial, as well as characterization of the left ventricular parameters, including arch morphology and left ventricular function and volumes. And it's right ventricular volume, in fact, for patients with severe regurgitation that has proved a strong prognostic factor and correlates with neuroendocrine markers and also with objective exertional tolerance markers. The ventricular progressive dilatation and the severity of the regurgitation is a strong marker. So how do we measure, the ventricles in patients with Ebstein anomaly using our conventional 2D MRI at the present time? And this is done either in the short axis or the long axis view, essentially with a Simpson's method of summation of cylinders. And whatever view this is done, the crucial thing is to be able to match the slice position that's being measured to perpendicular views in all planes so that precision can be gained with determining the margins of the ventricle and the atrium. And although this is very time consuming, with systematic process and careful standardization, it really can be done reproducibly and reliably and accurately. And so with careful delineation of the ventricle using the 4-chamber view, the slice position relative to 4-chamber view, outflow tract and vertical long axis view in diastole and in systole, we can generate the ventricular volume in diastole and systole, therefore the stroke volume, therefore the ejection fraction. And combining that in a comprehensive way with the arterial flow parameters, we can calculate the cardiac output, we can calculate the regurgitant fraction, and we can also measure the shunt in complex patients with bidirectional shunts in this disease. And now with increasing sophistication of the software for cardiac MRI, we can look at multiple deformation parameters and also tissue characterization at high resolution. And increasingly now 4D flow techniques are going to play a bigger part in characterizing and classifying the ventricular and valvar hemodynamics for Ebstein malformation. But all of these techniques suffer from a fundamental problem of MRI. There are 3 main challenges that MRI has. And the first one is really arrhythmia, which is common with Ebstein malformation. So without a regular RR interval, it is much more difficult to get very high resolution images and high quality images for this disease. And the spatial resolution also makes it more difficult for tissue characterization and for feature tracking of the right ventricular myocardium, because it is a very thin, very fine structure. Similarly, this is also a great challenge for specific tissue characterization of the right ventricular myocardium. And temporally, the temporal resolution of cardiac MRI is many times less than the temporal resolution of echocardiography. So all of the functional parameters have a much lower temporal resolution, and all of the indices are load dependent, or most of the spatial deformation parameters as well as the systolic functional parameters are load dependent, which again is a challenge when we are looking at the effect of load altering interventions. But having said all that, MRI, because it's comprehensive view of the whole hemodynamic picture, has been very, very useful for assessing the efficacy of the development of the cone procedure for repair of the Ebstein valve. So MRI was able to show successfully the improved left ventricular filling dynamics of the cone procedure, and this correlated well with exercise and exertional parameters measured objectively. But not all cone repair of the valve was successful, and we noted in our team that many patients were not hemodynamically improved after having had cone reconstruction, even with a competent valve. Whether there were dilation problems with significant wall stress post-surgery, or whether there were problems with a restrictive hemodynamics and the requirement for a cavopulmonary shunt. So just adding that it was also possible with cardiac MRI to closely depict the reasons for surgical failure. So the preoperative images for this patient are shown in the superior panel. In the inferior panel, soon after repair of this valve, there was dehiscence of the inferior portion of the annuloplasty, even though the actual cone mechanism remained intact. So we attempted to develop a relatively simple and reproducible tool to try and select the best cases for cone reconstruction. And I think cardiac MRI helps with this enormously. The reason for MRI being very reliable is the ability to standardize a vertical long axis view through the ventricle, which is a much more complex and difficult view to acquire with echocardiography. So the rotation angle is actually an angle from the aortic hinge point of the valve around to the systolic coaptation margin of the valve during closure. And this angle, which we'll call the Ebstein valve rotation angle, actually gave a very nice prediction, a very clear prediction of the success of the cone procedure for different patients. So a patient without Ebstein anomaly has 0 rotation of their effective systolic closure plane. And this patient has a moderate degree of rotation. These 2 patients in the right-hand panels have significant rotation, very little redundancy of the anterior leaflet, and a very small preoperative functional right ventricle. This rotation index was in fact first described by Christian Schreiber and his team, and it correlates with the Carpentier classification of the valve and can be measured with echocardiography, but I think less reliably. And the index predicted post-surgical dehiscence of the valve for adult patients, so predicted more tension and an increased likelihood of dehiscence. So paradoxically, the cone reconstruction was less successful in ostensibly less severe Ebstein anomaly. And that's because it was related to a less ample anterior leaflet, more fibrosed, less regurgitation from the valve, but a smaller RV with restrictive hemodynamics. And also in pediatric patients, the extent of rotation of the valve very strongly predicted the postoperative need for cavopulmonary supplementation of left ventricular filling, even with a competent valve and a good cone repair. So I'm hoping I've shown you a number of examples of how MRI can contribute and add to the huge contribution of echo in helping us to get very granular data and very specific data to make all the decisions that are needed for the lifetime of our patients with Ebstein malformation. Thank you very much for your interest in this topic.